total knee techniques and outcomes.
Thank you very much. Yeah, we now move to revising a uni to a total. So usually the conversion is fairly straightforward. For instance, dislocated bearing, ultimately the mobile bearing can be very mobile, and if that cannot be contained, the revision is fairly straightforward. But you clearly need, as you've had a sense throughout all of this session, that the indications are key. The mobile and fixed issues are fairly similar, but there are one or two differences. Obviously, dislocation can only occur with the mobile. In fixed, wear is still a bit of an issue. There is this issue of patellofemoral joint progression. So what I plan to do in this talk is concentrate on tips for indications and for surgery. So the first tip is avoid revising for unexplained pain. We know that with a total knee, but obviously with a uni we think, well, if we revise it, they'll do well. But we've looked at this. I showed you this earlier. If you have a post-operative score that's worse at 6 months than it was before surgery, there's a 6 times higher chance you'll get revision with a uni compared to a total. And we've looked at those people that presented after revision, and we found that in 3/4 of them that were revised for unexplained pain, they failed to get better. The revision is easy. Resist the temptation. It's just like a total knee. You investigate them, you look at their hip and back, you make sure that there's a normal radiolucency. Do not bone scan them because it will be hot and you will revise them unnecessarily. You need to try and treat them conservatively. But pain, unless you've revised them unless you've done the initial operation for early arthritis, pain is becoming less and less of a problem. Now, we've talked of the issue of the problem of revising patients who've got normal x-rays. If you've got a good joint space, 5 or 6 millimeters, in other words, a normal knee, if you operate on them, they don't do well. So just operate on patients who have end-stage arthritis. Now, there is this issue of radiolucencies, which bedevil partial knees because we don't worry about them in totals. This is something we used to see a lot of, but now with our more conservative technique and our larger tibial template, we see it less and less. But most of you who will see this with an x-ray that's taken just tangential to the implant will assume that it's loose. We've had patients who have had this revised without any symptoms, but of course if they have pain and that, you will think they are loose. That is not loose. It does look loose, but it isn't. You'll have to work hard to remove that. For loosening, you need to have a pathological radiolucency, which is thick, poorly defined, and there's migration. So just remember that. This is the physiological radiolucency. It begins in the first 1 to 2 years. It remains static thereafter. It's about 1 millimeter thick. There is a sclerotic margin. That's the key. If you look around the edge here, there's sclerosis. It's not a source of pain, but many people could imagine that. Now, obviously, in the old days, particularly if you look at the mobile bearing, particularly with one peg, loosening was a problem. Now, most of us in this room, even I, could diagnose femoral loosening with an x-ray like that. But actually, femoral loosening used to present with much more subtle features. That was the reason for going from 1 peg to 2 pegs with phase 3, and it's virtually disappeared since then. But the